Good evening. I'm Dr. Allan Perel, and this is Conversations in Medicine. This program brings cutting-edge medical topics to the Staten Island and tri-state community. Tonight's topic is going to be very interesting for us. It's in the field of pediatrics. We're going to be talking about developmental milestones in children. We see so much of autism, attention deficit disorders, children who need help in school, even much younger, trying to make the diagnosis of kids in the autism spectrum, who have autism spectrum disorders, that we really have an expert here who's going to try to make this very complicated topic simple for us, simple for parents, to try to get an idea of when to be worried. Sometimes we see in medicine, and as we see in all fields of life, an idea of being knowledgeable of when to know to get help is so crucial. So my guest is Dr. Miroshnichenko. She's the Chief of Developmental and Behavioral Pediatrics at Richmond University Medical Center, a good friend, someone I've known for a while.
Thank you, Dr.
And she does such a marvelous job at the hospital. I really can't say enough. So let's go over what, you have a long title, of course, and I'll tell you just a little story before you start.
Sure.
All medical students want to be pediatricians. Everybody in medical school wants to be a pediatrician, and then it always moves on into different ways. And I've always been envious of someone who's always found their first love and stayed in pediatrics. So tell me, what does it take to be a developmental behavioral pediatrician? So what training did you have?
Sure. Thank you for inviting me, Dr. Perel. It's my pleasure to talk to the audience today and share my experience and love for pediatrics and specifically developmental behavioral pediatrics. So I deal with children who are just born, for example, NICU graduate, up until 21 or 23 years of age. So it's a large spectrum, okay, age-wise. And I enjoy it immensely, starting from playing with younger kids, because all my assessments are play-based for younger children. So I have a unique opportunity to play with children. That's why I love my job. Moving on to teenagers, I can have mature conversations, I can really make an impact, and I can really connect them to services which are needed. And of course, the big partners are parents. So it's not only working with the children, but also working with the parents. That makes pediatrics so unique.
So to be a pediatrician, you go to medical school, of course, you pick
Absolutely.
Pediatrics. So tell me a little bit about the extra training that you have with regard to development.
So I graduated from Richmond University Medical Center Pediatric Residency Program, and I love pediatrics. I decided to get a little bit more on the field exposure. So I went to primary care, and I spent there about 5 years. And what I've noticed is that the most meaningful connections I had was with the families whose kids were affected. They had special needs. They needed me more than any atypically developing child. That's why I bonded with them. That's why I decided to go with this calling. And I applied for a fellowship, specific fellowship in developmental behavioral pediatrics. Spent 3 years in the training. Worked in New Jersey, several years there, and then it was an opportunity for me to return to Richmond University Medical Center, and I gladly took it.
And we're so happy that you're back. So tell us, do all hospitals have a department where there's a developmental behavioral pediatrician?
Unfortunately, the answer is no. And if you ask me how many board-certified developmental pediatricians are in the United States, it's less than 1,000. 994, I believe.
So let me just ask you, even before we get into the real topics of the medicine of this, the pediatrics of this, and diagnosis and definitions, let's talk about political correctness. Over the years, different terms have been used for children who are not typically developing. And a lot of people in our audience, nobody wants to say something wrong. I mean, there was a term mental retardation for a period of time, but now that's something that is stigmatized. You really don't want to say that. Even developmental delays are not the term that is sometimes used. So, and again, sometimes words, it's actually very important. Words are crucial. I mean, we have a TV show and we're talking, it's the way we talk to families, the way we talk to kids, talk to each other. Words mean a lot. So tell us a little bit about what are the newer terms and maybe why they're important for us to know.
Absolutely. As you correctly mentioned, we don't use the term mental retardation anymore. We use intellectual disability. And nowadays we concentrate on our attention on neurodiversity, okay? Even if the child is diagnosed with learning difficulty or learning disability, we try to explain to parents that it's just the brain wired differently. It doesn't mean that the child is not smart or he or she is not going to be able to achieve certain things in life, okay? So neurodiversity is very important nowadays, and we tend to use people-sensitive language. For example, we do not say autistic child. We say child, people first, with autism, or child with cerebral palsy. We don't say wheelchair-bound child, we say child who uses a wheelchair. And that makes families to feel better, more empowered, and more accepted in the society.
And that's in school too. We want the teachers to do that. We want
Sure.
administrators, secretaries, people. It's because, again, the term, the person first. In my own office as a neurologist, I don't want to ever hear the patient or the MS in room 3, seizure in room 4, someone had a stroke in room 5. I mean, they're on the chart, the diagnosis is there, but it's a person with a seizure, it's a
Yes.
person with a stroke, it's a person with multiple sclerosis. And I think that's become the big part of it. Because so many people are so worried about the political correctness of what they say. And I think a lot of what you see is how they say it. If
That's
somebody
true.
says things in a loving way, even if it's an older term that really is not proper maybe for now, at least if it's said with love and caring, it's different than if someone says it in a derogatory way.
And it's all about education. It's all about educating the parents, as you said, educators in school or preschool, and just talking about it freely without stigma.
And when we talk about developmental delays or intellectual disabilities, a lot of times what we're looking for is what the person can do, not what they can't do.
Yes.
I use an example sometimes with patients who have some memory problems. It's not how many green lights you go through, but the problem is the red lights. Same thing here. We look really, but in the other way with kids, we want to know what kind of things they can do and how well they're doing. So we're going to jump right in. So we wanted to talk about the developmental milestones. So parents, and we have a very huge young population on Staten Island who are having kids. And how would you know, even if you talk to your general pediatrician who's always looking up people's noses and ears and do all kinds of things, they've stigmatized my kids for years with that stick, the idea of what's normal. So we have people leave the hospital quickly. They don't go to school for a couple of years. So it's up to mom and dad and friends and people to be able to make some assessment. And I know the pediatrician is a major part of that. And I think you've got some literature where we're going to go over a little bit and things that we can learn from. But being able to see whether someone is developing typically is so crucial. So tell me a little bit about the program with Milestones and what mom and dad have to figure out.
Sure, and as you pointed out, parents have to have an idea what is the milestone, okay? What can they measure? For example, if my child is not able to walk independently by 18 months, is it abnormal or normal? On the other hand, if my child started to speak at 9 months, saying mama, dada, or give me, okay, give, this is something that parents can say, this is typical or this is atypical. So the program that I'm going to mention is, and this is a Spanish version of it, which says that this is a free resource available in different languages, English and Spanish included, okay?
So many languages, including Russian, including Chinese. I mean, I'm just trying to go through.
About 7 languages, okay, if you request. And the program is based on AAP, American Academy of Pediatrics, recommendations, and it comes from Center for Disease Control and Prevention. The program is pretty old. It's about 20 years old. But Milestones were revised about 2 years ago in 2022. And they kind of revived the program and they want parents to know about it. It has an opportunity for parents to, I'm just going to show the little leaflet, to have an app and download it through the App Store, Google, for example.
What's it called? So
The program's name is Learn Science, Act Early. And what we want parents to do is learn signs, what is normal or abnormal. And if you see the brochure, you can take a look and see that typical milestones are listed there. And not only the milestones are listed, parents can figure out what activities can they do with their children to promote their development if children are delayed or child is delayed. So learn signs and then act early. The second part is basically promoting the action from the parents. And the action would be talking to the doctor about their concerns, asking for a referral, calling early intervention. And
So now we have this up on screen. So maybe you can help us a little bit. You can actually look at on the screen with us. So what kind of things, and there are a lot of things here, and it's hard to read. This is not really a brochure itself. We could find this online. Let's go through the numbers. Here they say 6 months, 12 months, 2 years, 4 years. So what is a typical 6-month-old? What should the parents be looking for?
Sure. First of all, we have to mention that there are different domains of development: social emotional domain, language domain, motor domain, cognitive domain. So it requires a lot of knowledge, and developmental milestones are different. For example, typical 6-month-old will be able to roll from back to front and front to back, okay? They will attempt to sit independently. They need a little bit support, but they're starting to do that, okay? They can hold their bottle. They can start transferring from one hand to another. They bubble, okay? They smile, they respond to their caregiver's face, and they interact, trying to engage, making sounds, okay? That would be a typical 6-month-old.
Okay, how about 1 year?
1 year. So the child is attempting to make a couple of steps, and the milestones were recently revised. So nowadays we say, even if at 15 months, if the child is trying to do it, between 12 months and 15 months, this is normal. Okay, so they have to say mama, dada, and plus one more word. They are definitely engage more. For example, if mom is showing something, hi Johnny, take a look. Beautiful balloon. Okay, the Johnny would be looking. They can try to get mom's attention, extending their hands, pick me up. Okay. They can play peekaboo by 12 months. So it's a lot of different skills that they acquire between 6 months and 12 months.
And at 18 months, that becomes really very crucial. If kids are a little bit slower, that's where diagnosis of some concerns come in. So tell us about 18 months.
18 months indeed is a crucial period, okay? And that's where we start screening for signs of autism spectrum disorder. Okay, so what would be the early signs that the child might be on the spectrum or have symptoms of autism? Deficit in social communication, and this is eye contact, for example, lack of it, lack of modulation of eye contact. No words by 15 months. If the child is not making any words or continues, for example, to babble from 6 months to 15 months, it's a concern definitely. And some repetitive behavior. At this age, we usually ask parents, have you noticed that the child has unusual hand movements? For example, flapping of the hands or flicking of the fingers.
Okay. We're going to jump ahead to 4 years because, again, I want to be able to, I'm going to have us take down the flyer.
Yes.
And we're going to talk a little bit more about it. So at 4 years, what do we usually say?
4-year-old, fully equipped to speak, have a conversation, tell a short story. For example, Tommy comes from school very excited and wants to share the experience. Okay. Shorter sentences, nevertheless sentences, able to express wants, needs, and emotions. Okay, have friends, at least 1 or 2 friends, play appropriately with toys, and of course, able to walk, run, jump, climb stairs independently.
Super. So thank you. We're going to take down that. And I had a question that I've always been curious about. Sure. Whenever my kids were in school and we were looking at it, there was always one family whose child was taught to read at I don't know, 2 days of age. The 2 or 3 year old who was taking a book, and as a neurologist, I've never seen that. I've seen literature basically saying that it really doesn't matter what age you do. By the time you get to high school, college, it sort of all catch up. So tell me, what do you think about the pressure that some parents put on kids about reading early, about trying to be well advanced, or doing some of the, and again, I'm not setting you up for the answer, but just to be a normal kid doing different things.
Sure.
What are your thoughts about that?
I think the pressure comes from our educational system. We're trying to start school early, and a lot of parents feel anxious about it, that their child is not going to be prepared. Mm-hmm. Okay? So I think taking it with the goal of equipping a child to do their best is a good approach, meaning that, yes, we're going to participate as much as possible in pre-K 3, pre-K 4, but let's remember that it's still a child. So any interaction has to be play-based and enjoyable for the child. Okay? Otherwise, we see the situation where children are not motivated to learn, and they have reservations, going to school. They don't like going to school. That scenario is not a positive scenario. So yes, we are determined to start education early, but again, giving the child an opportunity to express what they enjoy in life, their temperament.
So let's go over some issues that we have. If you notice that your child is not at these milestones, it's important to know family history, whether mom and dad spoke at a certain age, but if you see that there's something wrong, and whether it's you or a friend notice there's something not right, and they go to, and we come up with a diagnosis, and we want to go over this autism spectrum mm-hmm. disorder. As we were talking before, a lot of physicians, we have people who have asthma, we have people who have high blood pressure, people who have a stroke. Very few people are given some kind of this diagnosis of a spectrum disorder. And I think we could all understand why, because some people are higher functioning, lower functioning, things like that. Tell me a little bit where the term autism comes from, how many people have autism. Mm-hmm. Again, I know it's more boys than girls. And really, what's the spectrum disorder? How do we know if someone had a child with autism? Do you want, is there a category, is there a 1 through 10, is there some way that they quantitate it? Mm-hmm. And because it confuses even a lot of healthcare providers, including myself, like autism spectrum disorder. So tell me a little bit about it.
It's difficult, I agree. It's difficult to understand for parents, and it's difficult to explain what is going on with the child. It doesn't mean that we struggle explaining what it is and what's the level of autism, but it means that we need to educate the families and to work with the families. So it's a process, okay? So we used to call these disorders pervasive developmental disorders, talking about the lower functioning kids, and Asperger's syndrome, talking about high functioning kids. Nowadays, it's all spectrum. You can make some distinctions, and I'm going to get to it. But let's first talk, what is autism? Autism basically comes down to two things: deficit in social communication and repetitive restrictive pattern of behavior. If we have these two categories of the symptoms, we can say that most likely it's autism if we cannot explain it by anything else, like intellectual disability or global developmental delays. Okay, certainly we're trying to get the age of the diagnosis to earlier age. The average diagnosis nowadays is around 4 years of age, and it's a little bit too late for the services. Okay. On the other hand, when we talk about the process of diagnosis, New York State is actually one of the states where early intervention can diagnose autism. And we're talking about age from 0 to 36 months. And truly, when we suspect autism, is basically between 15 months and 36 months. Okay? So when you said what parents can do to get the attention of the professional, I think the fundamental things that we want parents to know is that they can self-refer to early intervention. They don't need to get a pediatrician referral or a specialty referral. They can look up early intervention number, call the number, and get the services.
So if you think your child's not where you think they should be, the city has a program or is it a city or a state program?
It's a state
program where your child could be assessed.
Yes, and we're talking about, again, specifically children from age 0 months to 36 months.
Tell me about interventions. The concept of, first of all, does it really help? There's different kinds of interventions. There's behavioral interventions called ABA. There's all kinds of different interventions. Are the interventions tailored to the child, or does the child have to fit into the intervention? You know, sometimes there are certain things that are sort of very regimented for certain children to try to get there.
Sure.
And I'm just curious about how your rehabilitative team helps and works with these children.
And I love the term rehabilitative team. It's a team effort, definitely. And if we're specifically talking about a child who is on the spectrum, autism spectrum, the services have to be tailored, okay? For example, innately, child who is on the spectrum will have language delays, speech and language delays. So they will need speech and language therapy. In school, outside of the school, outpatient therapy, okay? A lot of children who are on the spectrum have sensory processing issues. So what can help? Occupational therapy. So the occupational therapist is going to be part of the team. Now, behavior therapy. A lot of children on the spectrum would have behavioral issues. ABA, Applied Behavior Analysis, is the scientifically proven type of therapy which we have been using for about 20 years. Long-term therapies. We have to explain to the parents that, yes, the chances of getting better in terms of function are high. Can you recover from autism? About 9 to 10% of kids, especially high-functioning kids, would lose the diagnosis when they are older. But we're talking about 90% versus 10%. Okay? So long-term intervention team. And major part of the team is school, educators. So children with these special needs, regardless if they are on the spectrum or not, they are entitled for special services in school, special education services, individualized educational program, and the program has to be tailored to, again, needs of the child.
And the behavioral issues with autistic children, with children on the spectrum, I mean, you know, there's a higher incidence of seizures. I see many of these patients as adults, and there's a higher incidence of seizures. But some of the behavioral issues that sometimes become so difficult for families to cope with, do you usually get a psychiatrist involved in the case? Do the developmental pediatrics do it? Does the general pediatrician do that?
Sure. We strive, and nowadays it's a lot of conversations about introducing mental health issues, behavioral issues in primary care. So we work hand in hand. For example, we share a lot of patients. Dr. Mendes, Dr. McDonough in the clinic would refer to me. We discuss cases, and even if I prescribe something for behavior, I usually update the pediatrician. And, for example, if I'm not available for a week, I'm doing CME or I'm off, my colleagues would pitch in. Okay, so yes, pediatricians are equipped to deal with certain issues. For example, insomnia, which is very common in kids who are on the spectrum. Then developmental behavioral pediatrician is definitely, me, myself, equipped to deal with these issues. Do we use help of psychiatrists? Yes, absolutely, in severe cases.
Mm-hmm. We only have a few minutes left, and I'd be very remiss not to talk about something that's very common. Autism is seen in about 1 in 40.
54 children
54
nowadays. The rate of autism
and boys
is climbing
get this
up.
more than girls.
Sure.
But attention deficit disorder, ADHD, attention deficit hyperactivity disorder. Tell me a little bit about it, because again, we have so many of our viewers and so many of people out there who think that everybody in the room is hyperactive. You see someone who's fidgety, someone who can't focus,
Sure.
I had a person who came in who was working 3 jobs, and told me that at midnight they're tired and that they can't focus, and they wanted to know if there was anything I have that would help them get through that. I said, getting 8 hours of sleep or about that period of time probably would help. So tell me, in kids, how do we diagnose it? Again, we haven't talked about IEPs that much in school, and we're running out of time. But with attention deficit disorder, how do you tell a fidgety kid from a child who has a diagnosis?
Okay, so first I want to, and thank you, it's an excellent question because I see a lot of kids who are candidates for this diagnosis, or it turned out they don't have this, have something different. So to diagnose ADHD, attention deficit hyperactivity disorder, it requires a full evaluation, okay? Do we need to do any medical tests, for example, lab tests or imaging tests? No, it's a clinical diagnosis. But the symptoms have to be present in different settings. For example, if parents are concerned, have concerns and educators have concerns, or, for example, parents have concerns and a coach, sport coach, has concerns. This is two different settings. So it has to be number of symptoms. It has to be a duration of time, more than 6 months, okay? And the child has to be diagnosed before, or symptoms have to be there before the age of 12 years old. 12 years old. As I said, we have to make sure that parents complete necessary screening or assessment tests. We send the same type of tests to the teacher or to a sport coach. And then once we get the responses, we're going to sit together with the parents, go over the clinical history, get thorough medical history, get thorough physical exam, and based on that, arrive to the diagnosis.
Tell me about puberty and ADHD. So I think of young men, boys specifically, who are going through puberty. There's a lot of things that are happening, and girls too, of course. Yeah. But tell me about puberty with these kids who have difficulty focusing or really difficulty sitting still.
It's actually very challenging, and I'm glad you brought this the topic. If you are in a situation where a teenager comes in and they are more inattentive than anything, and they asking for medication, for potentially, right, saying that they have a friend who used the medication for tests and that helps, okay? So we are in a difficult situation then. We have to make sure that the symptoms were there before 12 years of age, so it entails talking to the parent, getting thorough history, as I said, and then giving an opportunity to this young man to do an adult ADHD form, assessment form. So if there are a number of symptoms and the symptoms are impairing their function in school and at home, then there is a possibility that it's truly ADHD inattentive type.
It's always interesting and very difficult to diagnose. So many kids, especially my kids who have just graduated from college, everyone, and again, not on a drug level, but before a test have shared a pill, and they do better on it. It really does help their focusing, and they're all set for this. And half the classes are again, not that this is some mill where everyone's doing anything else, are trying these different medications. And I think I've just seen so much of it in my practice where people want to be on these medicines because they think it'll help improve their concentration, their overall well-being, be able to work a little bit better. But it really is a very slippery slope in who we put on these medicines.
That's true. And I want parents and young people to get this message that the medication works only if the child has inattentive symptoms. Okay? First of all. Second of all, these medications are not really safe.
Okay. So I'm going to run because we're actually running out of time, and my producer is going to yell. Thank you all, and we hope we've learned a lot about children and young adults, and hopefully we'd love you to come back. Take care. Have a good night.